Neutropenia. Scenario: a 27-year-old man with epilepsy attends the emergency department with shortness of breath, dry cough, and a fever of 39 degrees Celsius. On initial investigation, he is found to be neutropenic and you are asked to see and advise him. His FBC is as follows: hemoglobin 13.8 g/dl, normal range 12-16.5, white blood cell count 2.9 times 10^9/L, normal range 411, neutrophils 0.4 times 10^9/L, normal range 27, lymphocytes 2.1 times 10^9/L, normal range 13, and platelets 201 times 10^9/L, normal range 150-400. Introduction. Febrile neutropenia. Febrile neutropenia refers to all neutropenic patients, neutrophils less than 2.0 x 109/L, who have a fever. Patients with a neutrophil count of less than 0.5 x 109/L are at greatest risk of life-threatening infection. Fever may be defined as two temperatures taken 1 hour apart that are both greater than 38.0 degrees Celsius or one temperature greater than 38.5 degrees Celsius. Neutropenic sepsis. Neutropenic sepsis refers to neutropenic patients with a severe illness caused by overwhelming infection. Signs of sepsis include tachycardia, hypotension, postural hypotension, tachypnea, confusion, a reduced consciousness level and fever, but not all patients have all these signs. Neutropenic sepsis is a medical emergency. NB. Severely neutropenic patients with infections may not appear at first glance to be very unwell, but this is misleading. They have a life-threatening illness and often deteriorate rapidly. Consider neutropenia before the blood count is taken when the clinical context is appropriate, e.g. in patients on chemotherapy or following a bone marrow transplant. Immediate action saves lives. When called by a GP, nurse, hospital doctor, patient, or a relative about a potentially neutropenic patient with fever, remember that all neutropenic patients with fever, including this one, should be considered to have the life-threatening condition neutropenic sepsis until established otherwise. What are the causes of neutropenia? Neutropenia can be either an isolated finding, as in this patient, or part of a generalized pancytopenia. Problems with sepsis tend to be more significant when the neutropenia occurs as part of a generalized pancytopenia secondary to chemotherapy. There are two likely reasons for this. The first is that chemotherapy causes mucosal damage, particularly in the mouth and gut, which facilitates the passage of organisms into the bloodstream. The second is that monocyte function is preserved in isolated neutropenia. These phagocytose bacteria in a similar way to neutrophils and offer protection against infection. The causes of neutropenia are listed in Table 8. History of the presenting problem. Respiratory sepsis. The details given strongly suggest that the presenting illness is respiratory. Is this pneumonia? Ask about rigors and pleuritic pain. Has he produced any sputum at all, and, if so, what color was it? But remember that sputum production is often a late feature in pneumonia. Check rapidly for other symptoms that might indicate a source of sepsis: dysuria/urinary frequency, abdominal/loin pain, diarrhea, skin infection/abscess or a painful joint. NB. Patients with neutropenic sepsis may only have vague and nonspecific symptoms such as malaise and lethargy. Other relevant history. Cause of neutropenia. The patient has an isolated neutropenia. Note the conditions listed in Table 8 and take a careful drug history. Ask about symptoms that might suggest a recent infectious illness. Could this be a post-viral problem, and for symptoms that might suggest an autoimmune rheumatic disease? Ask about a family history of neutropenia or blood disorders. Examination. The following aspects are particularly important. Check the patient's vital signs, temperature, pulse, BP including postural drop, respiratory rate, and pulse oximetry. Are they in shock? Check the Glasgow Coma Scale, if appropriate. Examine them carefully for focal signs of infection, throat, chest, and abdomen. Pay careful attention to the mouth and perianal area as sites of potential infection, as well as long lines if appropriate. Examine all lymph node groups. NB. Do not perform a digital rectal examination in a patient with neutropenia. This may cause infection. Investigation. FBC and film. Ask the laboratory to confirm the findings of the FBC by reviewing the film in the unlikely event that they have not already done so. This review would principally look for evidence of dysplasia, in particular for nucleated red cells, primitive myeloid cells and blasts in the peripheral blood, all of which would suggest marrow infiltration. If there is a history of recent infectious illness, then check a monospot test. Their blood tests. Check electrolytes, renal and liver function, calcium, immunoglobulins, and serum electrophoresis, and perform a clotting screen. Look for antinuclear antibodies, complement levels, rheumatoid factor and, if the patient is antinuclear antibody positive, double-stranded DNA antibody. Microbiology. Culture blood, urine, and stool. If there is a long line in situ, e.g. a Hickman line, take blood cultures from both the line and peripheral vein. Use a nasopharyngeal swab if there are symptoms of respiratory tract infection. Radiology. Perform a CXR, looking in particular for pneumonic consolidation. Bone marrow examination. This should be carried out in all cases without a clear cause of neutropenia in order to exclude bone marrow infiltration or failure. Occasionally, acute leukemia will present in this way. Other investigations. Depending on severity of illness and findings on pulse oximetry, is oxygen saturation 94% or more, check arterial blood gases. In this patient, who appears to have a neutropenic respiratory infection, high-resolution CT scanning of the chest and/or bronchoscopy with lavage and transbronchial biopsy may be required if initial cultures are not diagnostic and the patient does not improve with first-line management. Management. Underlying condition. Treat any underlying condition appropriately. If a drug is believed to be responsible, then it should be stopped. Neutropenic sepsis. Resuscitate if necessary. Administer high-flow oxygen, through a reservoir bag if needed, aiming for oxygen saturation greater than 95%. Establish intravenous access and infuse colloid or 0.9% saline to support the patient's BP. Administer broad-spectrum intravenous antibiotics. Most hospitals have a policy with regard to antibiotic use in neutropenic sepsis, but a typical recommendation would be piperacillin 4 grams 4 QDS and gentamicin 5-7 mg/kg daily, with gentamicin dose adjusted according to monitored levels, and recognition of the need for a reduced dose in cases of renal failure. Consider a urinary catheter and initiate an hourly input/output chart if the patient is shocked. Get specialist advice. Discuss the case with a hematologist. Consider the use of granulocyte colony stimulating factor. If not already in situ, consider insertion of central line to monitor circulation and aid treatment. Note that this may need platelet cover. Further comments. If the patient remains hypoxic, hypotensive, unstable or continues to deteriorate, then arrange assessment by the intensive care unit, ICU, team. Outcome is better if patients are transferred to ICU before they suffer a cardiac arrest. How long should you continue the antibiotics? This frequently depends on the individual patient, but a reasonable guideline based on assessment at 72 hours is as follows. If cultures are all negative and the patient is well and afebrile, stop antibiotics and observe. If the cultures are positive and the patient is responding, continue with appropriate antibiotics and stop the antibiotics not useful in the treatment of the identified organism. If the patient is not responding or is deteriorating, reculture and take microbiological advice. Consider alternative infective organisms and changing or adding antifungal, or antiviral or antipneumocystis, drugs to the regimen. Can neutropenic patients with fever ever be treated as outpatients? Yes, but only after discussion with a senior hematologist. Patients with neutrophil counts above 0.5x109/L, with no symptoms or signs of sepsis, who are clinically well and have good social support, e.g. do not live alone, and who can be brought quickly back to the hospital if they become unwell can be considered for outpatient oral antibiotic treatment with close clinical outpatient assessment. If they deteriorate, then they need to be admitted urgently and managed as described above. All fevers and suspected infections in patients with a neutrophil count of less than 0.5x109/L and all septic patients, regardless of their neutrophil count, should be managed in hospital.